Hello, good morning all. At the outset, I'd like to thank Dr. Ann for giving me the opportunity to talk to all of you. And I have see a lot of familiar faces here, parents whose children we have treated in the ICU. It is nice to see you all here. So basically, my topic is acute worsening, how we prevent it and how we manage it in the ICU. We have lot of cases and case scenarios here, which I'll be going through so that you get an idea as to what are the different scenarios in which patients land up in the PICU. Okay, so there can be some chest deteriorations in children with SMA. The children with SMA may have some post-operative care requirement in the PICU for which they are shifted. And sometimes these children also have fractures for which sometimes they need PICU care. And long-term ventilation, what are the options we offer to the patients in the ICU? And when do we talk to patients about palliative care? All this we'll be discussing today. So, as we all know, care of SMA is a multidisciplinary approach. So, a big team is needed to treat even a single child with SMA. So, we have a great team here. We have Dr. Naveen sir, who is our pediatric surgeon. We have Dr. Ann, who is our pediatric neurologist. We have Dr. Madhuri, who is our pediatric geneticist. And me and Dr. Lakshmi, we are the pediatric intensive care team. And we have other support from the physiotherapy team and the dietary team. So it's a big team effort which is needed to treat children with SMA, and so that has to be understood by all parents. So let me go through our first case. It's a 4-year-old boy with SMA type 2. So he presented to the pediatric team with parents complaining of persisting cough, cold, noisy breathing on and off. So this child was not admitted, but the child had been going to the pediatrician frequently and was taking oral antibiotics. The symptoms were better for some time, then again the symptoms were coming back. So the pediatrician outside were reassuring them that the infection will get resolved. However, we need to know the background information of this child. So this child had failure to thrive. So there was a lot of nutritional issue. The child had not gained weight as expected for the age and also had untreated sleep hypoventilation. And what happened next to this child? Let's see. So there were further series of events. So he was admitted as he had severe distress. That is, to tell in layman terms, he was breathing very fast. He was not able to breathe. So all those problems were there with the child. Then we did a chest x-ray. So you can see the chest x-ray, it's a very bad pneumonia what the child is having. There is a lot of congestion on both sides of the chest. We call pulmonary infiltrates. Both sides of the chest were involved. So this child was almost about to be intubated. So fortunately, we have a lot of new technology available to treat children with SMA. So our hospital is well equipped with BiPAP machines and cough assist machine. So first, any child with SMA who comes with acute worsening like this, we do give a trial of BiPAP because we want to avoid ventilation at any cost, because once we ventilate a child with SMA, it takes a very, very long time for us to wean the child from the ventilator, and it's very difficult to wean the child from the ventilator. So he was also treated with IV antibiotics, and slowly, gradually, the condition of the child improved. And gastrostomy and fundoplication was advised to the parents. The family was made to sit down. We have discussed with the family. We have counseled them that why it is very necessary for this child. Like I already told, this child was failure to thrive. The child was not gaining weight. So obviously the nutrition was lacking. Secondly, the child was getting frequent infections in the chest. So that is because, like already previous speakers have spoken about aspiration and GER reflux, which can predispose the child to pneumonias, recurrent pneumonias. So we emphasized as to why this gastrostomy and fundoplication is necessary for to avoid these admissions to the PICU, to build up the nutrition of the child. So that has been advised to the parents. And Naveen sir will be speaking about in detail about gastrostomy and fundoplication. His talk is following my talk. So he will be detailing about those things. So what basically happens when there is an infection? There is a respiratory failure. The child is not able to breathe. This is also contributed by the airway collapse. The airway of a SMA child is very dynamic, so it collapses. So we see whenever we take an X-ray, there's sudden one segment of the lobe has collapsed, And when we do physiotherapy, it opens up and suddenly we see that there is another segment of airway which is collapsed, because this is because the airway is so dynamic, it frequently gets collapsed. So the other issue is, because of this collapsibility of the airway, what happens is there are small air sacs in the lungs which also tend to close. And also, like already discussed, they have a reduced chest wall compliance, mainly because they have a weak intercostal muscle. Added to that, most of them have scoliosis. So they also have a restrictive lung disease component in addition to their weak intercostal muscles. So this is the reason why the children have recurrent respiratory infection, and they take a very, very long time to recover from respiratory tract infection. So basically, their muscles are very weak. They are hypoventilating, that is, they are not able to breathe properly, and their cough reflex is weak. They are not able to cough and bring out the sputum. So all this contributes to this vicious cycle where the infection, once it sets in, it is extremely difficult to recover early from the infection. So common issues in neuromuscular disease. So what are the causes? What commonly we see why children with SMA come with worsening? So muscle weakness. Basically, they have this problem of hypotonia and difficulty, and they also have breathing difficulty because of this intercostal muscle weakness. Since especially SMA type 1, the mobility is restricted. So they have a higher risk of DVT. DVT means deep vein thrombosis. That is, in the calf muscles, usually there are veins where the clot formation can occur because the limbs are not moving well. So these children are usually bed bound, and they do not have exposure to sunlight, and their diet is usually not adequate in nutrition and calories. So they are also prone to osteoporosis. Because of osteoporosis, what happens is the bones become very weak and fragile. So even a small movement or a small fall can, so like already discussed, they have scoliosis and they have swallowing difficulty. Many of the children with SMA have bulbar weakness, so they are not able to swallow properly. Their swallowing is not well coordinated, as a result of which they are more prone for aspirations. And subset of children with SMA can also have involvement of the heart. So when we say involvement of the heart, it means it can be that the heart is not pumping properly, or the electric connection, what we call it, conductivity of the heart can be affected. So the heartbeats can vary. Some children with SMA can have very high heartbeat, irregular heartbeat, that also can happen. So these are the common issues and common challenges which we face in the ICU, for which the children come. So like already told, everything has a multiple layer and multi-system involvement is there, hence the need for MDT. And MDT is very essential in ICU, especially we need the support of a pediatric pulmonologist, pediatric physiotherapist, and orthopedics, pediatric surgeons. So in the ICU, it's basically multidisciplinary. Whenever a child is admitted, always we will call Dr. Eileen, we will call Dr. Anne, because we have to start the child on BiPAP or cough assist. We need to know how many times we have to do the cough assist. So it is basically a multidisciplinary approach to treat a child with the neuromuscular disease who has an acute worsening. So coming to the second case, so SMA, as we all know, are of different types. Ramya has already highlighted on that. So it varies from case to case, and depending upon what type of SMA it is, how severe is the SMA. So this case 2 is about a 2.5-month-old baby boy. He's not diagnosed with anything. He just comes to the hospital. He comes with a very, very severe pneumonia. So when we examine the child, we see that the child is severely hypotonic and already has ankle contractures. So there was a very high index of suspicion of SMA in this child. When we did the X-ray, it showed a bell-shaped chest, and when we went back and looked at the history, there was a history of consanguinity. That is, the parents were related. So Dr. Madhuri has seen the child, and we went ahead and did the genetic test, and it showed SMN1 deletion, which was homozygous. So in this situation, it becomes very tricky, because this child is already very, very hypotonic, has come with a very bad pneumonia, already has ankle contractures. So the chances that the child will respond to treatment are little on the lower side. So all the pros and cons of treatment were discussed with the family members, and in view of the improvement being less, in spite of therapy, the parents opted for palliative care. So here what we need to understand is, we support whatever decision the parents are taking, If they want to go ahead with all the treatment, we are giving all the support. It is the parents' decision finally to take a call on how much they want to do for their child. And we are supporting in all way possible to treat the child. So the third case is of an older child. This is a 9-year-old girl with SMA type 2. So she is wheelchair bound. So she presented to the ER and was then admitted to PICU being suddenly drowsy. Now, why was she so drowsy? So given oxygen in peripheral hospital, and she became more and more drowsier after starting oxygen instead of improving. She did not improve. So once the child was received to the ICU, it was not in our ICU, it was in an outside hospital. Normally we start the children with SMA who have this breathing difficulty, drowsiness on BiPAP. Over a few hours, she dramatically improved on BiPAP. So we have to see the carbon dioxide here, it is 82. So it was a hypoventilation. That was the reason for the drowsiness. So there was a CO2 narcosis. We say that whenever the CO2 goes very high in the blood, the children tend to become very drowsy. So at this point of time, more than oxygen, they need a support for the lung. So to ventilate properly and to remove the carbon dioxide. So this child was put on BiPAP machine and settled, and she clinically improved rapidly after starting the BiPAP machine. So this reinforces the fact that why children with SMA need to use BiPAP. Because there are a lot of hypoventilation episodes which happen in the sleep and the CO2 can go up. And BiPAP helps to improve the, to avoid these episodes of hypoventilation. So during sleep, most of the patients, we advise them to use the BiPAP machine. So an SMA causes insidious respiratory weakness that often goes unnoticed. That is the reason why it is necessary to use this BiPAP machine. So coming to case number 4, it's a 2-year, 4-month-old girl with SMA type 2. She had recurrent chest infection requiring almost 6 to 8 times admissions in 1 year. So her sleep study was abnormal. So she was started on BiPAP. So it helped reducing the chest infections. Then later, we noticed that the weight gain was not good. She had to undergo a gastrostomy and fundoplication. Since then, she was free of chest infection for almost a year. So the fundoplication was done for this child. Now the child is 6 years old. She was doing very well. She was started on Spinraza. She became stronger, but in the winter, she got an RSV bronchiolitis and was admitted to the ICU. But she improved because she was already on BiPAP, already had undergone fundoplication. So her illness was not very severe, and she needed ventilation, which could be avoided. Only with BiPAP and cough assist, we were able to treat her pneumonia, and she was able to recover from the infection. So this is the cough assist machine. This Philips Respironic machine we are having in our PICU. So basically what it does is it simulates a cough, normal cough. So as I already told you, the SMA children have a weak cough. They are not able to bring out the sputum. So this machine does the job for them. So basically what it does is it gives positive pressure at a very high rate during inspiration and creates a sudden negative pressure during expiration. So there is an insufflation and exsufflation technique is what we call it. So when we put this on the child, what it does is we give cough assist at least 3 or 4 times a day, and we give it for 5 minutes, not more than 5 minutes. It helps to bring out the sputum. So this we routinely do in children who are sick in the ICU, who are being treated for pneumonia. So only contraindication for this cough assist is if the child has undergone a recent surgery like fundoplication, we do not want the abdominal pressure to go up. In that situation, we cannot use this cough assist machine. Or if the child is on ventilator with requiring high oxygen, that is the situation in which we are not able to use this machine. Otherwise, routinely we are using the cough assist machine to treat all children who are admitted with pneumonia to the hospital. So post-operative management, Naveen sir is going to speak after me, so I will not stress much on that. So basically, after the surgery, we receive infants to the ICU, mainly because of pain management, to manage the fluids, and until they are able to take enterally, we start the total parental nutrition. So most of the time, it's post-gastrostomy or post-spinal surgery. So now coming to this palliative care versus curative care. So it's an ongoing debate and very difficult for everybody who is involved, including the intensivists, the pediatricians, the neurologists, the parents and the caregivers. So it's an ongoing debate as to when we have to offer palliative care. But what we need to know is SMA is increasingly becoming treatable. There are a lot of drug options to treat SMA, and there are more drugs which are undergoing trial. So, even more drugs will be available in the future to treat SMA. And it is important to recognize chest involvement early to prevent this hospitalization. So, what we have to take home from this is gastrostomy. When there are failure to thrive, it's better to do a gastrostomy and fundoplication. When the child is having recurrent chest infections, it is better to start and having abnormal sleep study, better to start the child on BiPAP support, so that we can avoid all these unnecessary admissions to the ICU. So in case of complications in the SMA, especially respiratory ones, almost they are always predictable by and large and usually preventable, like I already told. So that is about the gist of my talk. And thank you very much.
Thank you, Dr. Ramya, for that talk that is really important in making sure that the number of hospital admissions are reduced. And,
now I request Mrs. Sumati, mother of one of our SMA kids, to please offer this memento to Ramya ma'am.
You may have to stand in the front so that they can take a picture.